Hello, everyone. Thank you guys for coming today. Sorry I'm not able to be there. I like to record this video in place of giving the lecture in person. I have not given the Thursday lecture yet, so hopefully this video includes everything that I'm going to talk about on Thursday. But if it doesn't, I will let you guys know. So I want to give a little bit about a little education, if you will, on the finger thoracostomy. I'm sure a lot of you are familiar with this, and a lot of you have been trained on the chest tube. So this is replacing the chest tube in our protocols, as you guys already know, and should be much more simpler, much more effective, and literally much more easier to do because you're not having to suture in a chest tube, hook it up to a pleural vac, all this other stuff. But I want to cover a couple things. First of all, being one, why we do it. Second of all, a little history behind it. Third, being the NAMSP position statement on it. And then fourth being a video that kind of walks you exactly through how to do a finger thoracostomy. And then hopefully we can do some demonstration or something that we can do some hands-on practice of what I hope to do, even though that's not going to be possible through this video. But that's what I'm hoping to do on Thursday. Without any further ado, though, let's see what we got. So starting with, let me get my thing fixed up here. I apologize. So starting with the NAMSP position statement. This is the position statement released by the National Association of EMS Physicians. This is done in October of 2024, so less than a year old now, and kind of goes through and highlights when we should be treating pneumothorax, how we should be treating pneumothorax. It's got some pretty big authors on there. Kinjay Naba from UCLA is up there. A very well written position statement. But I want to highlight a couple things on their recommendations that I think pertains to us and finger thoracostomies. So here's their recommendations. First one being that we should not be performing pleural decompression on patients with simple pneumothorax, but should perform pleural decompression in patients with tension pneumothorax if it's within our scope of practice. Fortunately for us, it's within our scope of practice. So that's there to highlight the fact that we are decompressing tension pneumothoraces, not just simple suspicion of a possible pneumothorax. Second one being pleural decompression should be performed in patients with traumatic out-of-hospital cardiac arrest if there are clinical signs of tension pneumothorax or suspicion thereof due to significant thoracoabdominal trauma. An empiric bilateral decompression, however, is not routinely indicated in the absence of such findings. This is very much in line with our protocol in that if you have a traumatic arrest with someone with blunt trauma to the chest or to the abdomen in the region of the chest, then it's appropriate to do finger thoracostomies in that patient. However, if they don't have any of that signs of trauma, let's say they got a gunshot wound in the head or they're missing a limb and they're bleeding out on the road, it's not appropriate to do decompression for those patients. So this is a chest x-ray, and what I really want to highlight here is what a tension pneumothorax is, to kind of review the physiology of a tension pneumothorax. Now, obviously, pre-hospitally, we're not looking at a lot of chest x-rays, obviously. But for people that haven't ever seen a chest x-ray before, this is a single upright view of the chest. Highlighted here in yellow, I've highlighted the right lung. And what you see here is that lung's completely compressed and air is black on chest x-ray, I'm sorry. So that air, for whatever reason, has escaped into the right pleural cavity and is compressing that lung. Now, interestingly, I don't see any obvious rib fractures on that right side. If you look up here to go along with that, you have a little bit of tracheal deviation to the left. Interestingly, though, you've probably been taught that tracheal deviation is a sign of a tension pneumothorax. But if you look more at the top of this x-ray going into the neck, you can see that the trachea is midline. So if you see tracheal deviation in the neck of someone, that's a very late finding of a tension pneumothorax. So let's go over again, because what a tension pneumothorax is, what signs and symptoms you're going to see in relation to that. So respiratory distress, I think that's a pretty obvious one. Tachycardia and hypotension. As you increase the pressure in the chest and you shift everything to the left or right side, depending on what side the tension pneumothoraces is on, you're going to decrease return of venous blood. You're going to crush the IVC, the inferior vena cava, and you're not going to return blood back to the heart. So what you're going to see is the heart do a compensatory mechanism where it increases in tachycardia, trying to pump that same blood around, but you're going to see hypotension because there's no venous turn back to the heart. Diminished or absent breath sounds, you're not going to have any breath sounds, or at least diminished ones on that right side. As you can see, there's no lung there to give you breath sounds. And then tracheal deviation, like I said before, that's a very late finding for us in the tension in someone that has a tension pneumothoraces. So let's go over a little bit of history about this. As you guys know, I'm a huge data guy, and I believe that decisions made without data are destructive. So I try to base all of my guidelines, all of the protocols, and everything I do based on data. So for us, there's a couple of things we need to point out. First, there's been a little history of, you guys are very well aware. There's been needle thoracentesis, or where you insert the needle. Pleural decompression used to be with a needle, and we tried that for a while. We all know that doesn't really work really well, and I'll show that in studies here in a moment. We tried chest tubes pre-hospitally. Those work. They definitely do work. However, carrying all the supplies necessary to hook it to a PleuraVac and do all this stuff is very time consuming. Teaching and keeping the skill updated to where you have to maintain proficiency in suturing and how to best suture one of these things in and what keeps it from getting ripped out, all that type of stuff. We were barely looking for a better alternative. So what we've kind of moved to is a finger thoracostomy, which you decompress the chest, that will release the tension pneumothorax, and then you're done. There's no really need to put a tube in there anymore, at least in the pre-hospital setting. So this is a study performed. Look at the failure rates of pre-hospital decompression after severe chest trauma. And what this looks at, this was a retrospective study done between 2009 and 2015 at a level 1 hospital where they tracked all trauma patients. They tracked a little over 2,200 of them. And what they were looking at was how often this procedure occurred, and then how successful was it. And what they really looked at was needle thoracentesis versus tube thoracostomy, because no one's doing a lateral thoracostomy in the field, at least not here in the United States. So what they said, so they took 6 years. One thing I really want to highlight by the orange arrow here is the period, right? They looked at 2,261 charts, and only 24 of them did the patient have actual need for decompression. So as you can see, this is a very, very rare procedure that you're going to do, and it may happen once or twice in your career. You're not doing it that often. And so what they found with this was, looking at the green arrow down here, was the pre-hospital successful release of the tension pneumothorax, okay? So it was reported by 83% of paramedics when they performed a tube thoracostomy. So we know the chest tube's pretty effective, right? But when they did a needle thoracentesis, only 18% of people actually had confirmed decompression of that tension pneumothorax. 18%. And when they CT'd 5 of those people, right, the needle was either removed, the catheter was either not there, or better yet, they didn't even enter the pleural space at all to even decompress that chest. And even one patient had no pneumothorax at all, which highlights the fact that it's very hard to identify pneumothoraxes pre-hospitally anyway without the use of ultrasound. Here's another one, the comparison of out-of-hospital finger and needle thoracostomy performed by ground emergency services. Now, this was performed at the University of Texas, and I want to highlight another thing about this study. So, retrospective cohort study, meaning that this is just thought-provoking. There's not really big guidelines that are developed off retrospective studies. But what they have is 34 patients, groups were matched, meaning that these patients had similar trauma, they had similar ground transport times, they were all taken care of by paramedics. So they were pretty much apples to apples, if you will. 15 of those people underwent finger thoracostomy, 19 underwent needle thoracentesis. All 15% of finger thoracostomy patients sustained a cardiac arrest prior to arrival. Interestingly, I think that goes back to their EMS protocols to where they had to have cardiac arrest to actually perform a finger thoracostomy. Of those, 20% got return of spontaneous circulation. When they looked at the needle thoracentesis, 6 out of 19 of those patients suffered cardiac arrest and had a return of spontaneous circulation of about 66.7%. So as you can see, you initially think that, hey, look at needle thoracentesis, you get a better Ross rate. Not that many people went into cardiac arrest. However, if you look at the rate of successful intrathoracic decompression, which is what we're trying to get to here, we're trying to release the tension pneumothorax. 93% of the finger thoracostomy people had decompression, whereas less than half of the needle thoracentesis patients had successful intrathoracic decompression. Just highlighting again that needle thoracentesis is not the best thing. So let's look a little bit at our guideline here to really bring home what our clinical indications are. So For me, in these guidelines, what you need to do a finger thoracostomy is hypotension. So you need a systolic blood pressure of less than 90. You have to have a history of blunt trauma or blunt thoracoabdominal trauma or blunt trauma to the chest or trauma to the chest, whether it be penetrating or non. And then you need signs of shock. So you need jugular venous distension, right? You need tracheal deviation away from the site of the injury. As we said, that's a very late finding. You need absence or decreased breath sounds on the affected side. And then you need hyperresonance to percussion, possibly. That's where you tap the chest, and you may hear that, you may not. And then increased resistance to ventilating a patient. Those three things with the setting of a hypotension with a history of trauma to the chest indicates the high likelihood of a potential tension pneumothorax. Now, I've also had a caveat here in patients in traumatic arrest with chest or abdominal trauma with whom resuscitation is indicated, they may require bilateral chest decompression, even in the absence of the above signs. Obviously, if you're doing active CPR, the chances of you finding some of these signs, including the hypotension, is obviously not very likely. So if you have someone that has thoracoabdominal trauma to the chest and you want to work the traumatic code and you think there's a high likelihood based on mechanisms they could have a tension pneumothorax, then you have the ability to decompress both sides of the chest if you think the juice is worth the squeeze. Contraindications for us is the absence of clinical indications, obviously, or patients who are hyper and normotensive. So if you have someone that has a normal blood pressure and they're doing well, leave that chest alone. Don't put your finger in their chest. Just get them to the hospital or get them to the aircraft. Whatever you need to do, don't decompress. We don't need to be decompressing people that are normotensive. Below that is the procedure, which we will go over again in person. It's a step-by-step of how to perform a finger thoracostomy. The big one, if you look at number 3, right, anesthesia. If you have the ability to do that, I think it's worth it, obviously. But in a traumatic arrest patients, I have it there in bold, you don't need to anesthetize them. Just put your finger in their chest. It's a life-saving procedure. They're not going to feel that if they're in cardiac arrest, all right? Now, one thing I want to highlight before we get more into exactly how the procedure works is this neurovascular bundle. Let me see if I can bring my mouse over here. Right here is the neurovascular bundle. This is obviously the posterior ribs coming off the spine. And as you can imagine, these loop in front of you to connect up to your sternum here. This is your aorta, just to give you a little bit of orientation here. And what I want to highlight here is the neurovascular bundle. So when we're talking about doing a chest tube and we say go over top of the bottom rib, that initially took me a long time to really conceptualize in my head. So I bring this up so that people that struggled like I did get a visual of what we mean by that. And when we say, let's say you're at the 5th intercostal space, so 1, 2, 3, 4, 5, here's rib 5. I tend to go up to the 4th intercostal space, so I'm higher. Right here, when they say go over top of the bottom rib, rib 5 is the bottom rib. Go right over top of that rib, and you would be right here in this area, which is going to avoid the neurovascular bundle, the intercostal artery, intercostal nerve, and the intercostal vein, which is housed below on the bottom portion of the rib right here. So if you go over top of the bottom rib, hopefully you avoid these structures, is the reason why we say that. All right, give me just a second. I'm going to bring up a YouTube video I did not create this video. However, I think it's an excellent video that highlights how to do the finger thoracostomy that will actually show you step by step how to do it in place of me actually being there in person. Here's the YouTube link for any of you guys that would like to record this or want to go and try it later or watch it later. I'm sorry. Let me get to where I need to be here. Oops. Sorry, I apologize. All right, so let's see here. Now, as you see here, you want to identify the mid-axillary lines and what his tops at the superior and the inferior mid-axillary line. In this procedure, if you're ever in doubt, always go higher than what you think you need to go. If you're thinking that 5th is too low, please go higher, kind of up into the axilla region, right at where the axilla starts. This is a case where you want to be a little bit higher than lower. You don't want to put your finger into the abdomen if you can avoid it. You make a simple 2 to 3 centimeter vertically horizontal or vertical incision down into the subcutaneous fat there, and then place your finger in. You want to kind of bluntly dissect to your finger till you feel the actual rib musculature there, and then taking a pair of Achilles, it's going to take a little bit of force, but you want to go through the chest wall. All right, bigger, stronger men, bigger, stronger women. It's going to take a lot of force. So it's a constant pressure into that chest. Once you're there, widen with the Kellys there and open up that musculature there to release the air. Once that's happened, or at least the air blood, once that's happened, the procedure is pretty much done. All right, you put your finger in there, swirl your finger around, and make sure there's no adhesions. I'm gonna pause the video here. The big point I want to emphasize to you guys is please, please, please try to avoid, if at all possible, getting your finger cut on the ribs. I've been cut by a patient twice. Both of them have been within a finger thoracostomy and a lateral thoracotomy, where I've put my hand into the chest and got my finger nicked on a broken rib. All right, so try your best to be gentle, but when you insert your finger, kind of do a 360 with your finger and see if you can feel the lung. If you feel the lung, you know that you're in the chest, and the procedure is pretty much over at that point. You've decompressed any tension pneumothorax is there, any tension hemothorax that's there. And in our protocol, there's nothing left to do. Here, you see him do the 360 motion. This is just an excellent video done in a cadaver lab. You can, once you're done, you can start CPR, like they say here, and see what you have. If you don't get anything out of the chest, or the chest is empty, you can leave it open, not put anything there. If you do get return of spontaneous circulation, then you need to put a chest seal over this. Otherwise, you just have an open pneumothorax. So you need to put a chest seal in this way, or a 3-way chest dressing that you will see them place here. And that's your chest seal there, obviously, and how that works. Now, this part we're not doing. If you watch the video, you will see them put a catheter into the chest. That we are not doing this. I do not know why they do this. This is not accepted by anyone that I know. You're literally just going to put that bad boy into the lung and cause a huge bleed, or suck up half the lung parenchyma into this decantos catheter. So we are definitely not doing that. Do not do this. I'm actually going to close that out. All right, so getting back to the video here, this is a little, like I said, a little simple video over the finger thoracostomy. I really want to highlight the importance of it. I think it's a great move for our services. I think it's a great move for you guys as critical care paramedics. You are definitely the best ones in the service to do it. I trust you guys to do it. So if it's indicated, please don't hesitate to do it. If you have any questions or concerns, please don't hesitate to reach out. I'm available 24/7, 365, and I appreciate you guys. Thank you.